Hey everyone, and thanks for coming and spending some time with us. We appreciate your attention, and we hope that this becomes something that you can take back to your practices and understand how real-world outcomes can influence and radically change the way we deliver pain care. Thanks to John for that kind introduction, and Jason and I really look forward to having this conversation with you all surrounding a topic that's near and dear to both of our hearts.
Yeah, and I would like to echo also. I mean, John has done a tremendous job in growing Celéri to what it is today. And as Michael will describe, and as we will chat throughout the presentation tonight, this was born out of a necessity to help guide care more appropriately and more intelligently. We were delayed in an airport in Dallas and came up with this strategy in, I think, providing a patient-centric effort for every single clinical encounter. And it's been overwhelmingly successful in my practice, not only taking care of patients individually, but then cross-referencing how we manage patients with certain disease processes and how we may be able to engage in meaningful inflection point care sooner.
When we think about pain care, we have to think about pain in the context of the biopsychosocial model. And we all learn this as fellows, we learn this in our practice, and we understand that pain is not a disease of just where it hurts and how much it hurts. It involves every aspect of your life, your well-being, and it's influenced by other things that you may or may not have control over. To treat the whole patient with chronic pain is to treat their biological, psychological, social, and intellectual concerns regarding and influences into their disease state. One of our close friends and colleagues in Australia, Dan Bates, said it best when he said that pain is a social disease, insofar as the stigma, the isolation, the mood, and self-efficacy and self-esteem that come along with the chronic pain state. It's very important for us to look at these folks as whole patients, not just radiculopathies or post-laminectomy syndromes, etc. That also means that our measurement scales need to adjust to take into account these very important domains that influence the chronic pain state. Jason, do you want to talk about this slide?
Yeah, I mean, this was something that really struck me, and I've seen this during this pandemic that we've been facing, where people feel physically distanced and socially isolated in managing their chronic pain, and I think we've done, I don't know, maybe 15 or 20 webinars talking about emerging from COVID-19. I mean, I'm here in California, and so our governor just announced that we have the ability to resume elective procedures, but keeping people engaged in their care and letting people know that someone is aware of how they're doing is critical. And it struck me, we all know that anxiety and depression go hand in hand with chronic pain, with comorbidities of up near 40 or 50%, and not qualifying how that impacts their pain care is ridiculous. And so I think that's why this biopsychosocial model has become so popular. And looking at this information that we have in front of us here, essentially what this says is for even rarely depressed people, more than 50% of them would rather take a year off their life than be depressed. I mean, that's crazy. And that tells you that neglecting that part of their pain and that part of their well-being and globally appreciating how that impacts how they engage with their loved ones and with their businesses and with their professional life is ridiculous. And so having a tool that allows to measure this in a validated way to create a common denominator amongst the patients in your practice is critical. And I think that, again, this was part of the reason why Michael and I developed a operationalized way of using a tool like the Promise 29 to better care for patients.
Yeah, and I think that one of the most important things that we can understand in pain care and interventional pain care, and certainly when we talk about neuromodulation, cost effectiveness and the opportunity to quantify and justify how and why we're helping people is extraordinarily important. And I think that all of us know when you have a patient who comes into you and they tell you that they had 80% relief, but their pain score goes from a 6 to a 4, that the math doesn't make sense. And the reason is not that patients are bad at math, although some of them very well may be. I'm bad at math. The fact of the matter is that there are so many different factors that are not necessarily summed up into a unidimensional linear pain score. The importance of this paper, which values health outcomes in the United States in terms of what we call quality adjusted life years, that is, how much of your time on earth would you give up to avoid living with X? It's very important that they compare depression in these red, green, and blue lines. I'm sorry, pain in these red, green, and blue lines to depression in the purple, blue, or teal, and orange. And what you notice is that to avoid rare, sometimes, or often depressed states, patients are willing and interested in giving up years off their life to avoid that. You don't see nearly as many people making that trade-off for pain. And that's something that was really interesting and striking to me. At the end of the day, and this goes back to what I just said, is that bad data in leads to insufficient evidence out. So linear pain scores, 0 to 10 FACES scales, do not represent the multidimensional pain experience. And we as a group need to radically change the way we're understanding the impact of chronic pain on our patients, to both guide care, to understand what treatment success means, and to ultimately measure what matters so that we can address the things that matter the most to patients, just as evidenced by the fact that mood is a much higher value to patients in general than pain.